Welcome to the award-winning AUA Leadership and Business Podcast, an official podcast of the American Urological Association.
Welcome to the AUA Leadership and Business Podcast, where urologic professionals experience the practical application of business acumen essential for success in today's dynamic professional landscape. I am Dr. Micheal Darson, and in today's episode, we will discuss the rise of digital men's health and direct-to-consumer services. Joining me today for this discussion is Dr. Logan Hubbard. Dr. Hubbard is an assistant professor of urology specializing in male infertility, sexual medicine, and reconstruction at the Department of Urology, University of Minnesota. Prior to his academic appointment, he completed residency in Texas at Houston Methodist, followed by a fellowship at Henry Ford in Detroit, focusing on andrology, infertility, and reconstructive urology. He is well published in these fields of urology with current research and publications in the area of digital men's health. Dr. Hubbard, welcome.
Yeah, thank you, Dr. Darson, for having me. I appreciate it. Happy to be here.
Well, this is certainly an interesting topic and one that's very current. So let's start from the beginning, though. Why don't you give us some of the historical perspective of telemedicine and direct-to-consumer services?
Yeah, so, just off the bat, it kind of helps to I feel like they get lumped in a little bit together in terms of what's the difference between telehealth, what's direct-to-consumer services, because there is a bunch of overlap. Telehealth tends to have kind of prior patient-provider interactions, whereas direct-to-consumer care, and these are kind of, I'll refer to them as DTCs, just so we don't have to say that over and over. But they're a lot more episodic. Their website's kind of like HIMS that are focused kind of on convenience and minor acute issues. And kind of a big difference is they don't always, sometimes they do, but don't always have prior patient-provider relationships. And there really was kind of the rise in the late 2010s. So HIMS, I believe, came about in about 2017, more or less. At least the launch was. I'm sure it was developed well before that. And, there's a lot of factors that kind of led to the rise. I think the easiest thing to put your finger on directly would be kind of the COVID-19 pandemic for those of us who kind of remember what it was like beforehand. There was a huge rise in digital health in general after that. But in reality, there was digital health even dating back to the 90s. So the VA, for instance, used digital health to talk to soldiers abroad so they could get, healthcare that may not be, available in like Afghanistan or Iraq, for instance. Neurology used it for stroke diagnosis in the 90s. That they were actually the ones that kind of set the standard originally. Pediatrics used it for underserved children. But, when COVID-19 happened, that really supercharged things. And I think if we kind of remember the CARES Act, before, it's easy to kind of forget, I use telehealth almost every day in practice. And it's easy to kind of forget that, prior to the CARES Act, there was, you couldn't take telehealth visits from your house, for instance. There was only certain platforms that they would actually bill you, or you could actually bill for, rather. There's geographical restrictions, which there still are to a certain degree. But, beyond that, it really kind of changed the landscape. And I think that, in addition to some smart people in both the medical and kind of the just political field, kind of saw the writing on the wall. I think this is obviously urologic numbers, but about a third of urologists are obviously going to be out of practice by early 2030s. And there's about only 10% of those are going to be filled with rural vacancies, so to speak. So you can obviously see that there's going to be a big disparity between people who need care, especially urologic care, and the actual ability to deliver that.
One of the things that you just mentioned was how things changed after, pre-pandemic, and then the what kind of kicked in because of COVID. It's my understanding that some of those changes are getting ready to go back to what I consider kind of the draconian measures of the pre-COVID telehealth. Do you have any updates on that?
As far as the pre-COVID, I've heard kind of rumblings of that. To be honest, I've heard that for several years now, and it hasn't really come about. I guess, with the new administration, I don't know exactly. I don't know that anybody really knows what the landscape is going to be like. But I haven't heard anything in terms of like concrete what it's gonna be.
Yeah, the last time I was on the Hill, there was a lot of bipartisan support for it, but as many things do, they get hung up in Congress, and now nobody really knows exactly what the state of it is.
Yeah, I haven't heard anything like actually coming down the pipe, but I think some of what we're going to talk about definitely lends itself to telehealth, and there's possibility that the direct to consumer care can kind of bridge a gap if it's left from telehealth from a standard kind of formal practice like we have, like in terms of like academic or private, that type of thing.
Got it. Well, so what are some of the main differences between standard telemedicine versus DTCs?
So we kind of mentioned the role of providers. The DTCs don't often require prior provider visits, which can sometimes, which we'll talk about, I think, at some point in terms of like safety, for instance. But they use kind of what's called a store and forward model, where patients have responses to online questions, and then that's stored and then forwarded to a provider, and that's what's called asynchronous visits. And so that's where you actually can have providers not see the patients at the actual time of filling out the forms. So you can imagine that there's generates some randomness to that. I think a lot of us got into urology for kind of the patient interactions and kind of long-term care. There's kind of a disconnect, hence the asynchronous, that moniker. And then, interestingly, a lot of times mandatory follow-ups, or there's no actual regulation, or there's no standard for mandatory follow-ups. There's only a few sites that even have that mentioned as a requirement. But, what they do lack in certain aspects, like we talked about, they do have a strength in terms of access and immediacy. So availability, I'm sure, just like you, there's, I often hear patients talk about how long they had to wait to get in to see me, and I definitely sympathize for that with that. And so, with access, there's apps that they have that, there's a sense that patients can get a bit more of an immediate access to somebody who can help them with their problems, which definitely has power to it and definitely carries with it, the power the patients see.
Interesting. Now, do DTCs, do those bill through outside of insurance entirely, or how does that work?
I think they bill as well. They bill sort of like we do, because they do see physicians, so they have to kind of have a standard billing practice in the same way. And so, yeah, long story short, yeah, they essentially bill in a similar regard.
Okay. What's the full spectrum of digital men's health beyond just telehealth?
Yeah, I wanted to definitely touch on this, just because obviously it's a digital men's health talk, and in the grand scope. So, beyond just the telehealth, there's obviously significant advancements. Probably don't need to tell anybody who's listening to this in terms of like AI, and that also goes into machine learning, predictive modeling, and those have been shown to have important benefits to clinical diagnosis, statistical projections, things like that. And there's, other things like robotics, wearable devices, which I think are, aside from the robotics standpoint, I think the wearable devices as well as, AI are kind of the future of the digital men's health sphere.
Now, when you're talking about like encompassing machine learning, robotics, smartphones, what are you trying to get across with those kind of? I don't know how like robotics fits into this, for instance.
Yeah, so I would say from the robotic standpoint, definitely a little bit less in terms of like this kind of telehealth, digital in that sense. What I would say is would be using like AI, for instance, to integrate, what you see in clinics. So one of the future directions we were going to kind of talk about, I was going to kind of talk about would be, for instance, like looking at Peyronie's disease. There's AI that is working on doing like predictive 3D modeling, essentially, for Peyronie's disease, that would kind of allow you to have better surgical kind of prediction of what it's going to look like, and plan a little bit better. And the same would obviously be true probably to a much greater degree in terms of being able to plan for like a partial nephrectomy, for instance, with like more advanced 3D modeling than kind of the CT scans and some of those can provide at the moment. So it would be kind of an integration of using all those features and things that you can gather in clinic, like imaging, pictures on your phone, et cetera, to kind of make a full picture from a planning standpoint, I would say, in that specific example.
Okay, that's pretty clear. What are the factors men are looking for in digital men's health that are leading to the overall rise in seeking digital care?
Yeah, I think this is pretty important. I mean, from a sociologic standpoint, there's younger generations coming up that, now have had smartphones, have had technology, have had access to that kind of, again, immediacy, that dopamine kind of reward response pathway, to where there's kind of, an immediate answer to things that you want. And then, they're also more apt to use Zoom, and they're also more apt to use kind of those platforms like Zoom, things like that at work that potentially the older and, more senior generations aren't quite as comfortable using. And that kind of, goes into a convenience aspect that, for instance, telehealth and direct-to-consumer care have, that patients actually are more interested in the convenience aspect than any other aspect of the telehealth platforms. So there's been some Dutch studies, for instance, where they've looked at kind of shame, for instance, and this is more specifically in terms of like men's health specifically. So for instance, ED, but they've looked at like shame or embarrassment, things like that, in terms of cause and effect of using telehealth. And over 50% convenience was much more of a factor versus about 20-ish% in terms of shame and embarrassment as causes for using the platforms. And that holds true for the DTCs as well as telehealth in general.
Yeah, I mean, obviously it's a very personal subject, and there's always, I mean, you can't really tell a patient how they're, or predict how they're going to act. I mean, all you can be as a generous listener, and so that's very interesting though, that they find that the convenience aspect is so like double the importance of the embarrassment factor, basically.
Yeah, and I mean, to be honest, when I've done some research in this area, and I was actually pretty shocked, because if you had asked me before I knew that statistic, I definitely would have said that, patients are probably looking to come to us for, avoidance of, having to talk about, especially if you're, for instance, seeing, potentially female urologist, and you're worried about erectile dysfunction or Peyronie's as a male.
Right.
I would say that would be more what I would have said. But, if you think about it, I mean, the large networks, like for instance, where I work at, there can be not insignificant barriers for patients accessing care, whether it's, getting through the telephone system, getting to the actual right provider, getting to, instead of just seeing a general urologist, if you need to see a specialist for instance, like Peyronie's disease, if only one person in the practice does it, there's, I think another Australian study said 80% of patients were, stated the convenience and flexibility were actually the big feature, in their entire health system.
Yeah, it's also interesting. You mentioned, aging generation and comfortable with, their smartphones and stuff. And as it so happens, I left my phone at home this morning, and I literally could feel the difference in my head of not having, it's amazing how much we use our phones, like every minute of the day.
Yeah, and I think there is some leverage that these direct-to-consumer care, and I think the telehealth kind of uses in terms of kind of getting patients to access that. And I kind of mentioned it a little bit, but I think there is a little bit of that dopamine reward pathway about getting, instant access, instant relief. And I think that's a very human and a very, I think, well-known feature of just cell phones, social media, those types of things that you also can leverage in terms of ads, for instance, for direct-to-consumer care, that I think people can be susceptible to.
There seems to be one of the points here, that kind of a high level of perceived personalization with these strategies. Can you go into that a little bit more?
Yeah. So, there was a study that showed that about 75% of patients who were using telehealth, this was actually not just in the sexual medicine kind of environment. This was kind of just telehealth in a large system. Actually felt more in charge of their healthcare, more in charge when they were using these direct to consumer care and telehealth. And so, I think that it kind of goes back into not feeling like a cog in the system, right? If you just feel like you're another brick in the wall, then you're less engaged. You feel like you're maybe not making decisions for yourself. Where I think that there's kind of the idea of, I chose this, I chose the provider, I chose exactly what I want. I have kind of, total control over my own healthcare. And I think, even though, there's some questions about safety, there's some other things about, telehealth that we can definitely get into, but I think there's not a doctor out there that wouldn't take a more empowered, involved patient in their own healthcare. I'm sure, there's plenty of family medicine doctors who, are trying to get patients to take control of diabetes, for instance. If you have 75% more empowerment and you feel like you're in charge, then, that often I think will translate to improved outcomes, which is really at the end of the day, the goal.
Would you say that that also encompasses telehealth? And I'll give you an example of why I asked that.
Yeah.
I practiced for almost 20 years in Arizona, and with COVID, I mean, we would have patients that would literally travel 2.5, 3 hours one way to, pre-COVID to get their PSA results and, and a UA, or something else. And
Yeah.
then now, I could feel the engagement from the patients when telehealth kicked in, because all of a sudden they didn't have to take their entire day to go get their PSA results or something like that.
Yeah, I think you make a really strong point. I mean, I had a very similar experience in residency of people coming from, rural Texas, things like that. And I was shocked a number of times at how far they had come for care. And granted, this was pre and post COVID, but I think, to your point, I think what telehealth does offer that is quite powerful is that, there's a large degree of kind of social constraints I think that America potentially has that other developed countries don't necessarily have, in terms of having difficulty getting off of work, having, larger distances to travel than you imagine, like Switzerland does, for instance, where, you can drive across in an hour or two from side to side of the country. So there's barriers that I think that are involved here that make people feel maybe disillusioned, or, I can't be in control of my health. Like you said, if I can't make it to my doctor's office, I'm not a good patient. What's the point of coming back for my post prostatectomy PSA check if I can't get off of work, or I can't get somebody to watch my kids? So
Right.
I think it offers a lot of potential solutions in that regard. And there's, some things that we kind of studied in one of my research, and some of my research was kind of the rural versus urban distribution. And, even though the urban obviously has more overall kind of search volume and usage just by sheer numbers, there's actually a good amount of kind of rural RSVs, which is like relative search volume, that indicates that, patients are eating up, telehealth services where they can, when it's feasible.
Mm-hmm. Those are really fascinating points, because like you said, every doctor wants a patient that's going to be more engaged, and that just opens up a whole new area of kind of empowerment that I hadn't really wrapped my head around until you brought that up. Great point. So,
Yeah.
Let's talk about it. I mean, is this for everybody?
Yeah. So, what the studies kind of show, and I think that this has been borne out a little bit in our discussion even, is there's kind of, the way I think about it is like middle of the road. So it's middle age, middle income patients tend to be the most avid users of telehealth in general, and especially kind of the DTCs. And so what average age means is about 40 to 55. So a German study, the median kind of sat almost exactly at 49. And then the income wise is about 50 to 100,000. So the interesting thing is that that's actually a bit more affluent than I think I would have originally kind of thought. And that number is skewed towards kind of the DTC number, because obviously if you were to pull that patient and you were to do pediatrics, a lot of those patients tend to be on Medicaid, for instance, things like that. So that kind of skews that number. So that is a more direct to consumer care number, but it does kind of give a sense of the men's health sphere, I should say. So that is kind of the men's health numbers, not the general population numbers.
So would it be that more affluent people are engaging this
in the direct to consumer cares? That's what the studies show. So about 50 to 100,000 is like the median income. And then the middle-aged men. So middle-aged men are actually about 3 times more likely to use the digital services in the direct to consumer care than the millennial generation is for now. And that obviously some of that is skewed towards age in terms of if you're older, you may be more likely to have erectile dysfunction, things like that. So you may be more seeking care than the millennial generation, but the numbers still are what they are.
Got it. So what specific patient factors influence usage?
Well, in terms of, so there's a couple of things. So I would say, for instance, high deductible insurance is definitely a factor. And so they did a study where about 30% higher usage was found in patients who had higher deductible insurance. And that kind of does make sense. And that goes into your billing question from before. And I think we're going to have a cost section at some point coming up, but directed to consumer care, for instance, and that branch of telemedicine tends to have lower upfront costs. And that's definitely appealing to patients who have significantly higher deductibles to the degree of about, 30% higher. There's also a lot. So they've looked at studies as well where they've looked at healthcare utilization, because if you think about kind of the typical patient that would be highly involved in terms of healthcare, you would think of somebody who maybe sees the doctor, sees their primary care for a lot of different issues. But the interesting thing, so they did a study from Hudnall and his group did a study that showed that actual medical utilization from a pure just kind of seeing a doctor standpoint didn't actually have any bearing on whether or not patients were using direct-to-consumer care, but certain diagnoses did. So testosterone patients, for instance, were over 3 times more likely than ED patients, which were more likely than kind of the other men's health issues to utilize telehealth and direct-to-consumer care. And I think that makes logical sense. There's not really any, why studies on that, but from a logical standpoint, I think there's kind of an increased utilization of like testosterone testing from family medicine, but there's also kind of the perception that testosterone is more of like a laboratory disease. You don't necessarily need an exam, both, from a primary practice and as well as from a kind of patient standpoint. The exam may not seem as important because it's, it's just a hormone. Why do I need to come in to see a physician to check the rest of my body when they can just, test my labs? So those kind of things do pop up. Another thing that's interesting that kind of predicts whether men will use direct-to-consumer care is actually use of wearable devices, arcing back to the digital health, so men who use like Fitbits, some of the other wearable devices, there's certain ones for like alcohol, nicotine, any of those devices actually predict higher healthcare usage through telemedicine. And I think, again, that signals there's kind of the patient who is comfortable with technology, who wants to utilize technology in order to kind of benefit their health and benefit themselves.
That's super interesting. The Fitness Tracker Association.
Yeah.
Got my Fitbit on right here, actually.
Yeah, that's right. There you go. Here we are talking talking digitally.
All right. So what are the downsides and the current limitations of digital men's health, telehealth, and DTCs?
Yeah. So I think starting off, one of the more interesting ones is if, so we basically started in who uses it with middle age, middle income, right? So around 50-ish to 100,000. So trying to square that circle in terms of some of like, because there's been a couple of other studies to show, for instance, that high proportion, like 75% in some studies, are actually coming from rural aspects. So squaring the circle of kind of that high income with like an extremely rural with extremely rural population doesn't necessarily mesh all the time. And so what we actually found in the study that I did was when we looked at like relative search volumes, some of the relative search volume from, in terms of looking at HIMSS and the direct to consumer care was kind of skewed towards high urban, high metropolitan areas, just from a pure population standpoint. And there was actually lower relative search volumes in several highly rural states. So in specific, like for instance, Mississippi, the Dakotas, South Carolina, they all had actually lower search volume. And I think, some of this actually has to do with the disparities that it can create. So a study from Micheal showed that older, racially kind of ethnic minorities, non-English speakers, and very, very rural populations actually have less access to telehealth and less access to it because there's less infrastructure. They may not have the money for, standard internet. You may have to travel, to an internet cafe or something like that to do a telehealth visit, which is less practical than just going to the doctor's office in the first place. So there is a question as to whether or not that actually the rural aspect is actually being addressed in the true sense, or whether you're actually just getting more affluent rural populations rather than people who may actually really need the services, which are the, kind of the underserved, traditionally considered underserved populations. Mm-hmm. So I think that's one definite aspect that's a downside for sure. I think the other one that's extremely interesting actually is cost. And I mentioned that briefly a second ago. Of the patients who use it, so Rodler did a study and only 5% actually quoted price as a reason to use telemedicine. But what others have actually found is that the initial visit for instance, for direct to consumer care is actually less than the overall first visit for a standard telehealth visit. But then after that, the prices kind of precipitously rise. And eventually the direct to consumer care is actually more expensive in cost analysis studies, which I thought was actually pretty fascinating. So, excuse me. For instance, 90-day supply of Cialis through a physician's office was actually much more expensive after you lump in the original visit, buying it from the actual site than an actual standard, practice, standard academic center, for instance. It was much higher. And so when they did a cost study of that, breaking it down, for instance, the HIMSS and Roman site, the price per dose for a generic Viagra generic sildenafil was actually $4 for 25 milligrams. And then it could get up to $12 because they have that chewable kind. They also have some compounded ones that are expensive. And then certain websites, not all of them, but certain of them require actually a subscription in order for you to get it. And so you compare that to getting sildenafil or Cialis, for instance, through GoodRx with a GoodRx coupon is actually about, I think they priced it out at about 20 cents per dose. So there's a huge difference in the actual cost. So I think that's a very underrated downside of those, that unless you kind of dig into the actual numbers, is sometimes not thought of.
That's a super interesting point, because I think, at least intuitively, I would have thought that these would have been more expensive over the long run, but I really hadn't figured out in my head how they got you on the back end. But that's it right there.
And I think it's interesting too, right? Because I think it's a combination of increased advertising, right? So there's, the last number I think I remember, and this was 2 years old now, but I think there was about $40 billion of like venture capital and $40 billion of like industry built into the DTCs. And so, it's everybody wants, everybody needs to stay solvent. Everybody needs to make money, but there definitely is a profit incentive as well into it. So, and I think that kind of bears true to that point. So, and it kind of shows you why I think testosterone is a highly sought after indication, and they're 3 times more likely, is because, if you can get somebody cheap, like you said, in the front end, and then have, labs every 6 to 12 months when they're stable, things like that, but build in price at the back end, then that's kind of an appealing business model.
Yep. What other downsides are there?
Yeah, I think the biggest, well, maybe not the biggest one, but I think one that bears a lot of mentioning is actually the safety aspect of it. And so one of the biggest criticisms of telehealth in general, I think, and this is true when COVID changed things, but also, throughout its infancy, for instance, is whether or not you can adequately deliver care. And so one of the big kind of downsides, obviously, is that you can't do an exam, which, for instance, in men's health, that can be kind of a big issue for Peyronie's disease, right? You can give somebody Cialis, but if you miss a huge plaque on their penis, you're not really doing them a great service, or you could be doing them a better service, I guess. What they found in actuality is that when they looked at how care was getting delivered and telehealth, and this is kind of going to direct to consumer care, for instance, was the AUA guidelines were being followed actually better in terms of erectile dysfunction when they broke it down by category versus testosterone, things like that. But there was, in general, omissions of validated questionnaires. There's obviously an omission of exam by definition almost. And then obviously longitudinal care, like we talked about. There's one, you don't necessarily need to follow up, as we discussed, but two, a lot of times because of the model that's used, you get a different doctor every time. And so you don't have quite that continuity that you would expect from seeing the same doctor kind of over and over. And so, that missing things in terms of conditions and comorbidities is kind of a big deal. And so I think if you look at the new Princeton 4 criteria, basically all of us who deal enough in erectile dysfunction, you should in theory be calculating an ASCVD score and kind of trying to cardiac risk stratify so that you can ideally catch, especially young patients with potential coronary issues. And then, in that manner, you can actually be making a bigger difference in their lives than just kind of fixing an erection for, temporarily.
Well, it sounds like almost the perfect and safe option is to have a doctor and then do a combination of in-office visits and the more routine stuff by telehealth. And that really kind of serves both sides.
I think that's really the best way to go, or at least in my opinion, is to have kind of a hybrid. Because to your point, you don't necessarily need somebody to drive 3 hours to come in to get like a testosterone check if they're been stable for 2 years, for instance. Like the likelihood that their hematocrit is out of control that far into replacement is super low. So I think that it's incumbent on us to be judicious about who you use that for. But in the grand scheme of things, when they've looked at actual adverse events and like major events in terms of prescribing medications, it's actually equivalent in terms of telehealth. So even though there's kind of some of those omissions, the actual prescribing of the medications isn't disproportionate in terms of like direct to consumer care versus like standard telecare. So there is that aspect in terms of safety, but one of the other issues is also kind of how information is presented. So when they looked at the information that was provided, there was actually a huge disparity between kind of standard telehealth and the direct to consumer care. And then if you broke it down, there was actually a disparity between information provided among the major telehealth players. So for instance, the big players like Hims and Roman actually had, when they did a LIDA score, which kind of looked at reliability, access to the information, it's like 41 different points. The scores were much better for the larger direct-to-consumer sites versus the smaller ones like Newman or Blue Chew, things like that. But when they kind of pulled the actual patients using that score, there was actually they actually found that the patients themselves felt like there was a decreased reliability and decreased kind of supplement performance, despite having relatively equal side effect profiles from standard medicine to the kind of direct to consumer care.
And let's talk about a little bit on the kind of the same topic about the male centricity of this kind of, telehealth, or, definitely DTCs and etc.
Yeah, so I mean, it's interesting. There's really, I think just now I recently saw there's actually something called hers that's coming out that's like supposed to be, I think, an equivalent female aspect to it. So this is like pretty brand new, but for the vast majority of the, of since their inception, it's been very male centric. I know this is a digital men's health talk, so obviously we're not going to talk too much female urology, but I think some of that goes into what they're actually going for, right? It's not telehealth for, neurogenic bladder or like overactive bladder, because that's not terribly profitable. I think what we're capturing in those senses is higher impact or kind of higher profile, problems like ED, low testosterone, that people also may have a bit of shame, like we talked about, even though that's not necessarily the main factor that they're looking for. But I think that's kind of what they're trying to capture. Mm-hmm. There's less incentive, I think, in terms of the women's health, at least at the moment. But I think that's kind of changing, which I think is good. And we kind of talked about it. I think when used judiciously, I think telehealth and even direct to consumer care, for instance, can be a powerful tool. But I think we'll kind of go to that in a second. I think there does need to be kind of some oversight and some regulation that we don't quite have yet.
Yeah, great. So let's wind down the talk by getting out your crystal ball and tell us what the future of the digital men's health sphere is.
Yeah, I think that any future directions talk in the current climate needs to probably start with artificial intelligence. We did mention a little bit earlier in terms of like Peyronie's disease with 3D modeling. There's some really cool stuff coming out, for instance, with cavernosal EMG, so electromyogram, kind of what neurology does. And so it's kind of looking at smooth muscle tone and trying to predict patients who are going to have early ED. I'm sure we've seen, young guys who fail medications, things like that, have some venous leaks. So it's kind of trying to predict that early. There's there's using AI to do testosterone questionnaires to try and get something that's a bit more standardized than just kind of what we use at the moment. And then I think one big aspect actually that it's a little bit outside of the realm of this talk is actually AI in terms of like global health. I think when used correctly, it's got language models, it's got machine learning where you can use it to kind of optimize like the interpretation of rare diseases, illnesses, etiologies. And so that can kind of, in a way, level the playing field, for instance, for patients rurally, things like that you don't necessarily need to go to, the highest specialist at the tertiary or quaternary center in order to get, high level care. So I think AI is kind of probably the biggest one. There's some work in virtual reality, for instance, in terms of optimizing telehealth. So you can get closer to an exam more or less. So instead of just a 2D, you may be able to do 3D in the future. And then that would also kind of help. There's some evidence to show that virtual reality, for instance, helps with procedures, like if you're doing injections or cystoscopy, things like that in the men's health realm, that, using virtual reality lessens the anxiety, lessens the pain burden the patients face when they're kind of doing that. Or vasectomies, for instance, is a big one. I've definitely noticed patients who are on their phone kind of looking at social media or something tend to be less stressed and less fidgety when you're doing a vasectomy, for instance. And then there's wearable devices like we talked about. Interestingly, the men's health, so the Fitbit, things like that, those are very, I think, well standardized. There's some, like I mentioned, in terms of like preventing or helping with like drinking too much alcohol, smoking. The men's health ones are actually, of all the things we've talked about, a little bit behind, which I think is unusual. Usually men's health, I think, is kind of on the cusp of technology more so. But there are a couple that are either out that still need to be studied, or being developed. I think one of the interesting ones, for instance, is it's a patch. Essentially, it's from Moari Medical, and essentially what it does is you put this patch on. It's for premature ejaculation. It's supposed to kind of disrupt the nerve signals safely, supposedly, coming from the penis to the nervous system in order to kind of increase ejaculatory latency. So, I think some things like that in terms of wearable devices have a lot of potential in the future for sure, but still needs a lot of study.
Yeah, that one sounds pretty interesting for sure. Anything else I'm leaving out that you'd like to mention?
Yeah, I'll just do a quick a quick plug for regulation. I think just quickly. I know that's definitely the least sexy of all the topics that we talked about. But digital medicine in general, and this goes true for telemedicine as well, is just there's virtually no regulation for it. And so I think if left to its own devices, artificial intelligence, for instance, things like that, I think can actually increase the disparities in medical health instead of actually benefiting everybody. If you're not careful about pricing people out, because not everybody necessarily has the infrastructure like we talked about to get AI type or telehealth, for instance. And I think that I don't know that I don't have any inside information on this in terms of whether it's going to be an eventuality, but I would say that if I ran the show, I would probably want to incorporate some of these things into the guidelines at some point. Maybe not this next round, but there should be some thought about how we actually do incorporate digital services into either individual guidelines, whether it's men's health like this, or whether there is, down the road a kind of digital health AI type of guideline, because there's also ethical implications. There's, about using patient data and things like that, or plugging it into AI. There's, patient care implications, HIPAA implications. So I think having something actually spelled out and at least loosely regulated would be a benefit to not just patients, but us as well, protective wise.
I think the AUA may have just gotten a volunteer chairman of that committee for that guideline.
Oh, really?
Yeah.
Did it? Okay. Oh, there we go. Oh, I was like, no way. I thought, I was like, man, I totally missed the ball on that one.
No. I think they're listening, and I think you just volunteered for it. And I think
we could definitely start thinking about it.
Yeah, this has been a really, really informative talk. Thank you, Dr. Hubbard, for sharing your time and expertise with us today.
Yeah, thank you. Thanks for having me. Happy to come back or answer any other questions, things like that people may have.
And thank you to our audience for joining us today on the AUA Leadership and Business Podcast. Until next time, continue to learn, lead, and excel.
Make AUA Leadership and Business your go-to podcast. Subscribe today by searching Leadership and Business on your favorite podcast app and enhance your leadership and business education needs. Until next time, continue to learn, lead, and excel.